Okay, hello everyone. Welcome to a Monday subspecialty VMR. My name is Madalena. I'll be facilitating today. And I'm really excited because today we have another clinical reasoning focused VMR. And we have some really exciting guests. So first, for the two case discussants, we have Dr. Sowda Ahmed. So Sowda is a PGY2 internal medicine resident at Brigham and Women's Hospital. And so I would love for you to kind of unmute and share, with us a little bit about yourself.
Hi, everyone. I am a second year at Brigham, still undifferentiated, thinking either cardiology or pulm crit. Originally from Minnesota, was born and raised there. Excited to be here.
Awesome. Thanks, Sowda. We're really excited that you're here. And I just saw that our other specialist discussant is here as well, Dr. Jill Harrington. So Dr. Harrington, she's a hospitalist and aspiring geriatrician at the VA in Boston. So Dr. Harrington, thank you so much for being here. We're really excited to have you here. And we'd love if you could unmute and also share with us a little bit about yourself.
Sure, I'd love to. Thanks so much. Please call me Jill. I think you gave the short version. I am a hospitalist at the Boston VA, one of the best jobs out there, and have a special interest in working with older adults. And hopefully we'll be moving kind of more into that space a little bit more formally in the next few years, but that's all a work in progress. Kind of all careers in medicine are like that. So there's always another corner to turn, more things to do, and really excited to be here with you all. I am hoping my voice holds out after 2.5 years. COVID caught up with me, but I'm doing okay. Just a little, if I sound a little weird, that's what's going on, but super happy to be here.
Awesome. Well, I'm sorry that you have COVID, and I hope you get better soon. I would actually wanted to ask, how you developed an interest in geriatrics.
So I was so fortunate to come upon some of it in my training. I went to Boston University for medical school, and it's one of the few medical schools that have required clinical rotations in geriatrics, extremely strong section there. I stayed on for internal medicine residency at Boston Medical Center. And again, they have just a wonderful geriatrics group, one of the oldest home care programs in the US, especially on the East Coast, and just had some great mentors. And I will say that it didn't kind of rise to the surface right away. We don't think about it. People always are like, oh, old people, I don't know about that. But, we have an aging population worldwide, certainly in the United States, and older adults are even more overrepresented in the VA population. So it is not uncommon that many of my inpatients are north of 80 years old, and they're just a truly special population. So, and just so complex. Their care is so nuanced, and it's really fun from an internist perspective.
Yeah, no, definitely. Well, thank you for explaining that. Yeah. Awesome. And we also have Gerline, who will be presenting the case. Gerline, do you want to unmute and introduce yourself?
Hi, everyone. I'm Gerline. I'm a PGY2 at Brigham, one of Sowda's co-residents, and I'm excited to present this case today.
Fantastic. Thank you. You've always bring such really interesting, challenging cases, so we're really excited for that. And we also have Promise, who will be doing teaching points today. Promise, do you want to unmute and introduce yourself?
Hi everyone, my name is Promise. I am a third-year medical student, and I'm really excited to learn from everyone here. It's going to be a lot of fun because it's a Gerline case.
Fantastic. And last but not least, we have Mukund, who will be scribing today. Mukund, do you want to introduce yourself as well?
Yeah, what's up everyone? I'm Mukund. I'm a fresh second-year medical student at UCSF.
Awesome. Okay, so thank you again for everyone who's tuned in today, and especially the two case discussants. So Mukund, you can go ahead and share your screen, and Gerline, you can go ahead and take it away.
Okay, so this is a 65-year-old male who presents with hyponatremia to 121 and decreased appetite. So he had a recent admission 2 weeks ago for acute on chronic back pain after he fell down the stairs. He kind of missed some steps while walking in the dark. He also had hyponatremia during that admission, and his discharge sodium was 127. And then I'm going to mention some past medical history in this aliquot and then include some more of the history in the second aliquot. So he has a history of cirrhosis in the setting of alcohol use disorder, no known ascites or SBP or history of esophageal varices or any history of encephalopathy. Also has a history of hypertension, BPH, had a TERP several years ago, and then a recent ED visit for an upper GI bleed in the setting of gastric and duodenal ulcers, and had some chronic back pain and lumbar radiculopathy, and an atrophic left kidney. I'll leave it at this for the first aliquot.
So do you want to take a first crack at this one?
Yeah, that sounds great.
Yeah.
So the first thing I'm thinking about with this 64-year-old male, when I see hyponatremia, I want to see if this is something that has happened before, which it sounds like he had in his last admission. So I'd love to go through the previous admission notes and see what his sodium was like, what they ended up doing for that sodium, and what he was discharged with. And then if we have any labs in between that recent admission and this most recent admission, I'd also love to get a good look at him to see, to kind of have an idea whether this was more acute versus chronic, and whether he's symptomatic from the hyponatremia.
Yeah, absolutely. So, so I see two things here, and I will absolutely echo what Sowda said. Firstly, getting a sense of chronicity is really, really important. And the fact that this guy was kind of living around, or at least in the upper 120s on his recent admission, is a little bit reassuring for this 121 in terms of how fast we need to act, how quickly we need to figure this out, how worried we are about him in this exact moment, versus the long term. Of course, we're worried about him in the long stretch, of course. And so that's certainly the first go-to, especially with these lab abnormalities. Has this happened to them before? What context was occurring at that time? Because frequently these are histories that repeat themselves. And so I agree, taking a look back at those previous circumstances. I'm also interested in kind of what brought this gentleman back in this time. That's something that's kind of scratching at my brain a little bit, because it sounds like we may have discovered some of this low sodium when he came in for this trauma, for this back pain. That's certainly a presenting thing, but this time he comes back with a lower number, and trying to figure out kind of what's bringing him back into care.
Awesome. I love how both of you touched on how important the time course is, and how whether this is an acute or chronic picture really influences how quickly we need to act, and also even the differential. I wanted to ask you both, I know hyponatremia can often be an intimidating topic for medical students, likely even residents. And I was wondering if either of you have just kind of a general way you approach hyponatremia in terms of the differential and like next steps. You talked a little bit about important questions, but if you could talk a little bit about just a general approach you have to that.
Yeah, I can take a stab at this first. I think for me, hyponatremia is always one of those things that I feel like I always have to pull up different schemas and kind of walk myself through it and make sure I'm not missing anything. But I think essentially, the things I think about is, number one, can we get some urine studies? And I think the three I usually think about are serum osms, urine osms, and urine sodium. And then from there, kind of as those labs are cooking, I love to get a good look at the patient. And the things I'm really thinking about, the schema and the way that it works, is kind of thinking about the volume status, whether they look hypervolemic or hypovolemic, and then kind of getting a good history about what they came in for, what their recent appetite was like, and kind of going from there. And then I think usually things always happen in the ED. So depending on what happens in the ED and how their sodium responds, I always look at that too.
Yeah, I think that's really a great breakdown. I tend to approach it first to make sure that there isn't a correction factor I need to do. Is this person extremely hyperglycemic? That's something that happens fairly often with folks, and their sugars are way up, and we need to make sure that that hyponatremia is actually true, and not pseudohyponatremia. And then moving on to the studies that Sowda pointed out, a hyperosmolar situation is a less common one. And so we frequently then move very quickly to the volume status assessment that she touched on. And I think that's how I usually approach, just try to start figuring out what buckets this might lie in, and what might be going on, even before I kind of know the past medical history, just to try to get a fresh perspective without coloring what's going on, because more than one thing's going on. And I saw a bunch of really great things in the chat, people throwing out, he fell, there's an SAADH component there, cirrhosis. These are all really good etiologies, and many or more than one of these factors could be playing into account. So I think that is the one thing that I think over time I've learned, that you could have multiple things playing into hyponatremia. We like them to fall into nice discrete buckets. So assessing the patient first in just the ways sort of mentioned, I think is a great approach, even before we start trying to pull in pieces of the past medical.
Amazing. Thank you both for kind of walking through your initial frameworks. Okay, Gerline, we'd love to hear the next aliquot.
Yeah, so some more information about his recent admission. So during that admission, he had some back pain that was he has chronic back pain that was slightly worse than that, since he had that recent fall that I mentioned. But during that admission, also had some lower extremity weakness and urinary retention. So there had been some concern for cord compression. So he had some imaging. He had a thoracic and lumbar CT during that admission that showed moderate to severe spinal stenosis and degenerative changes in his spine with slight compression of L5-S1. And an MRI was not obtained because he had some retained metal in his body, kind of unclear history about what that was. So during that admission, neurosurgery was consulted, who kind of just recommended medical management of this. And he was also noted to have a sacral decubitus ulcer during that admission. So some more kind of chronicity, as you guys have all been mentioning, to all of his symptoms and his overall health. So 6 months ago, he had a bad fall, and kind of that's when his chronic back pain really became worse in the past, recent time period. And he started walking with a cane, and his wife kind of has to help him with all of his activities of daily living. And then for the past month, he had some more frequent falls, including the one where it was kind of dark and he just tripped over in the stairs. But no focal weakness that he noticed. And his family members had also noticed occasional confusion at times, kind of a waxing and waning altered mental status. He's also had some poor PO intake for the past month, but no weight loss. And then last admission, he was given some fluids. His sodium improved, but then at discharge, he was told to not drink that much free water. And then in terms of bigger picture history, last colonoscopy was 8 years ago, and it didn't have any significant findings. And then right now, he's not had any nausea, vomiting, no chest pain, shortness of breath, has some urinary urgency at baseline, but no other new symptoms. And his sacral decubitus wound that he hasn't had any increased drainage from it. And then some social history, he used to drink 10 beers per day for many years, but hasn't stopped drinking for the past month. And he's around a 1 pack per day smoker. And then for some medications, he's on Tylenol, Dilaudid for his chronic back pain, omeprazole, and gabapentin. Sorry if I went too fast in any portion.
You're all good. I'm just going to format this.
So it sounds like there's a lot there. And I think just pointing out the things that specifically stood out to me, I think when you were reading that, the things that I was thinking about is this history of falls. Sounds like things have gotten worse since that initial fall, and would love to get more history of what was going on then, what caused it. And then it sounds like there's been repeated episodes that might be related to this chronic back pain and debilitation from it, but would love to get more history on that. And then I think the other thing I picked up on was the sacral ulcer that's I would kind of think about that developing over time. So it kind of makes me think, like, has he been bedbound for any period of time? How long has he been bedbound? Is that something that developed recently, or did that kind of develop after the fall? And then the other thing I heard was confusion. I'm not sure whether that's like related to causing the falls, or if that's kind of something separate. Has anyone talked more about that? Like, what does that exactly mean to either him or his family?
Yeah, in terms of the sacral decubitus ulcer, I think it was noted on the last admission, and since then he's kind of been in rehab for the past 2 to 4 weeks and hasn't had much movement because of this like back pain still bothering him. And then his original fall, I think, I'm not really sure about like the circumstances, the one 6 months ago that happened, but since then his back pain has been worse. And then the most recent fall was the one he kind of tripped over in this, he was in a stairway when it was like dark.
Yes.
Yeah,
Go ahead.
yeah, go ahead, Dr. Harrington.
So I was just going to say, so it seems like now we're kind of accumulating problems, and the question can be, and I think this was already raised in the chat, is the hyponatremia contributing to the falls, or are these two things kind of coexisting, just in parallel? And certainly, you know, down the line in terms of downstream effects, hyponatremia potentially causing some level of confusion. 121 is pretty low, although if his baseline or recent baseline has been 127, that's not a large change. But I think it's important to be thinking about all of these different factors, like suppose pulling up about falls. And when I think about falls, you know, I think about, you know, causes of falls extrinsic to the patient, and then causes of falls that are intrinsic to the patient. So extrinsic things are, you know, these stairs in the dark, right? So, you know, environmental factors that, you know, that are outside of the patient. He fell, he tripped in the dark. But then there are also things that are kind of intrinsic. So are these electrolyte abnormalities actually causing some flavor of altered mental status, that kind of very messy bucket that we often throw out there? Is he having some confusion? Like Sowda was saying, what is this confusion? Let's define this a little bit more. Is this related to a cirrhosis? Is he having some hepatic encephalopathy? I don't know. And then is it mechanical troubles? He's got all of this back pain, whether it's just the pain plus just kind of the mechanical difficulties with now sinus stenosis. You know, maybe he's having some changes in his gait and related to these. So, you know, and there are many, many more things. But I think kind of teasing out, certainly these falls are very much impacting his life. So teasing that out, I think is important. So it sounds like we have kind of accumulated this problem as well as the electrolyte abnormality that we started with.
Yeah, Jill, I love how you kind of walked us through that schema for falls, both extrinsic and intrinsic. And I think it's often so easy to focus on kind of the intrinsic, you know, electrolyte abnormalities, et cetera. But it's, I just really appreciate how you highlighted some of the extrinsic causes, like what are the environmental factors that could be contributing to that. A question I had both for you and Sowda is, you know, in this LQI, we got so much information with, there were falls, back pain, confusion, sacral ulcers that you guys all walked us through. And I'm curious, how do you kind of choose like what the center of gravity is, or which to focus in on when you have so much data thrown your way?
Yeah, I think that's a really awesome question. And I still have a lot of trouble with that and honing that skill for sure. I think a couple of things I think about, one is kind of what brought someone to the hospital and what that main complaint was, and can you use that? Another thing I also think about is, even if it was something different than what brought them to the hospital, is there something that either the patient or the family is the most concerned about? Because I think sometimes when you're having those conversations, one thing will be brought up and then kind of going from there, but always keeping the other things in the back of my mind. That's one way I kind of look at it.
Yeah, I love that. I think what I'm hearing is like using the patient's chief concern or the family's chief concern as your chief concern, something that you definitely need to address. That's really great. Jill, any other thoughts about, you know, separating signal from noise when you have so much information like this?
Yeah, I really tried to distill down, and this is kind of just a different way of stating exactly what Sowda said, was that what's going to keep this patient in the hospital. And sometimes that does align with the patient and the family's most important thing. And sometimes it doesn't, or maybe there's more than one thing. So, what absolutely is going to keep them here. But even if there isn't a truly discernible inpatient need, but it becomes the family's most important issue, that can be something that pulls that towards the center of gravity, because that is what's preventing the person from living their life, from going back to home or rehab or whatever that is. So I think that's what brings those things into orbit.
Yeah, thank you. Another question that kind of came up in the chat, also from the last aliquot, is you both mentioned assessing volume status for hyponatremia, and I assume the next aliquot will include the physical exam. And I was wondering if either of you could talk through how you assess volume status.
Sure. Yeah. So I've seen a lot of different things, and I know it can be really hard, and we do kind of a pretty bad job. But I think the things that I really like to use, I think one is just an exam related to just like listening to lungs, seeing if I can see a JVP, which I'm not that great at, but then also looking at lower extremities. And then I think it's always really useful to do an ultrasound, either take a look at the IVC and kind of see like the size and like collapsibility.
I completely agree. And I think the kind of undercurrent of this that we often don't say is that oftentimes we do a pretty decent job recognizing hypervolemia. All of the things that like Sowda was talking about really, and I think maybe we might be pulling in a little bias because we know this guy has cirrhosis, and that we're a little worried about that. But we're good at looking at lower extremity edema. We're looking for, looking at legs, looking at, at the belly, trying that fluid wave, pulling out the ultrasound, and looking for those things, checking IVC or checking for ascites. I think the area that we're not great in, and I think data has gone on to show that when people are dry, we're not always great at assessing if someone is dry versus euvolemic. That can be very tricky. Someone can look pretty euvolemic and actually be a little bit dry. And you won't find that out in terms of hyponatremia until you do some of the testing that Sowda had already kind of alluded to at the beginning of the hour. And so it can be really, really hard. But yeah, I find that assessing in all of the ways that she mentioned for volume up is much more readily easy than for volume down. And then trying to call euvolemia can be very tricky as well.
Thank you both. Okay, Gerline, we'd love to jump to the next aliquot.
Yeah, sure. So next aliquot, I have the physical exam and some of the basic labs. So on admission, he was afebrile, heart rate was 105, blood pressure 113/59, respiratory rate 18, and satting 96% on room air. In terms of general appearance, he was in no acute distress, but kind of intermittently falling asleep, but was rousing easily to voice. In terms of HEENT exam, pupils were equal, round, and reactive to light. His sclera was anictoric. Dry mucous membranes were noted on the admission exam. And then pulmonary-wise, his lungs were clear on auscultation. He was tachycardic, otherwise regular rhythm, normal S1, S2. No murmurs were heard. It was soft, non-tender, non-distended abdomen. And then the sacral ulcer was without purulent drainage, and the image was kind of compared to the prior image saved in the chart from the last admission, and there was no significant changes. And then there was some ecchymosis just noted throughout his lower extremities. And then he had 3+ edema on his left lower extremity, 2+ on his left lower that was noted, and no asterixis. In terms of neuro exam, he was oriented to person, place, and time during this exam. He had 5 out of 5 strength in his bilateral upper and lower extremities as well. And that's what I had for the exam in terms of the admission note. And then I can give some basic labs as well. So his white blood cell count was 14.5 with the diff of 75% neutrophils, 11% lymphs. Hemoglobin was 7.1, hematocrit 21, platelets were 303. His sodium, as I mentioned, was low. I think the one I've written is 123. I think 121 was like at his PCP's office. Now is 123. His potassium was 3.5, chloride 91, bicarb 20, creatinine 0.6. His glucose was 63. His albumin is 2.3, total protein 6. And then his ALT, AST, alk phos, Billy were all normal. He also had some other labs in the ED, had a troponin that was 33 and then trended to 30. And then NT-proBNP, that was 1,451. And ammonia, that was 39. A lactate was normal. And then serum osms were 253. Urine osms were 252. And urine sodium was less than 20. And then also had some iron studies. Ferritin was 192. TSAT was 10. Retics were 3.1. Then had a UA that showed 1+ leukocyte esterase, no nitrites, and 12 white blood cells, and no protein or blood. And had a CT head and neck that showed no acute abnormalities, and a chest x-ray that showed some mild pulmonary interstitial edema. This was, I think, maybe after he'd gotten a bunch of fluids in the ED though.
So I can start up with a physical exam. So, I think the physical exam here kind of pulls into that kind of like when we were talking before about volume status, about the kind of that tricky nature of the volume status. We have pretty, decent vitals, a little bit tachycardic, and a fairly reassuring blood pressure. Someone in the chat, I think, mentioned something about patients with cirrhosis having kind of lower blood pressures. That's something that's seen very commonly. And then, we're getting some of these senses of mental status, but we're not sure, probably still at this point, not sure necessarily what's underlying that. But then the rest of the exam until we get to the extremity is really just not a whole lot. Sort of talked about listening to lungs, trying to, if we're looking for hypervolemia, listening for crackles, things like that. We don't really have a sense of that on any of that. And then we do have this lower extremity edema. And so that might give us a little bit of sense of where that's going. But otherwise, I think that, the physical exam probably doesn't necessarily fully pull us into one direction or the other. It's good information, but it's certainly not, kind of a slam dunk case is solved.
And then I can talk a little bit about the labs. So just kind of going through it, looks like his white count is a little bit elevated. I'd be interested to see if that's a baseline for him. Is that different from his norm? And does he have any signs or symptoms of infection? And then with the hemoglobin, also kind of same thing. Is that the norm for him? Are there signs of bleeding? It looks like there is ecchymoses that are probably from the falls that he had, but would love to see more about the trend of the hemoglobin. And then going to the BMP, so it looks like the sodium is 123. I'd love to know whether that was after the fluids that he got in the ED or before, and kind of what that change was. But otherwise unremarkable. The LFTs are pretty unremarkable. And then kind of going through the urine studies. So with the serum osm at 253, we're kind of in the bucket of the hypoosmolar hyponatremia. And then looking at the urine sodiums next, kind of to give us an idea of whether SIADH is on or off. With urine osm at 252, to think of SIADH being on. And then with the urine sodium, would kind of put me in the bucket of thinking whether we're like in the hypervolemic heart failure, cirrhosis, nephrosis, or whether we're like more hypovolemic, hyponatremia, and there's like a low effective arterial blood volume. But with the edema that he has, I'm thinking maybe this might be more related to the cirrhosis.
Wow, that was such a brilliant analysis of those labs and also the physical exam. Thank you both for walking through that. I'm curious at this point, you know, Sowda, you especially have kind of walked us through the buckets of hypoosmolar hyponatremia, and then kind of breaking it down into, is this a hypovolemia picture or more of a heart failure cirrhosis picture? How would you make progress from here?
Yeah, no, that's an awesome question. I think for me, I would love to get a better information about like the inner volume status. So doing an ultrasound would be awesome. I think there's also other things that you can look at. I don't fully remember all of it, but kind of looking at the BUN to creatinine ratio, looking at FeUrea, and then looking at any signs of like hemo concentration to more think like, is this either hypovolemic or hypervolemic?
Great. And Jill, anything else to add about next steps and what you would do from here?
I think Sowda gave a great review of those labs. So I think I don't think I'm going to top her on that. She asked for those right off the top of the hour, and I think that was a great interpretation.
Yeah, pretty stellar. Awesome, Gerline. I think we can jump to the next aliquot.
Yeah, and I really like how you all are talking about how there's so much different data points, and this is the same thing we were going through when we were taking care of this patient later on. Was there was so many different things on history, so many different kind of findings, and trying to figure out which is actually going to help us move forward in terms of figuring out what's causing his presentation and his decline. So some more information, just kind of like interval history for the patient that happened, like clinical course. So initially, I think during the course of like early on in the admission, the ED, he was thought to be kind of volume down. So he was given fluids because it was thought to be kind of hyponatremic in that sense. And then around day 3 or 4 of the admission, he had an acute episode of hypoxia overnight and had a transient new oxygen requirement. So he underwent some more tests. He had a CT-PE that showed no pulmonary embolism, had some new moderate multifocal ground glass and interstitial opacities, and new moderate right pleural effusion, ascites, and mild anasarca. And then he had an echo that showed an EF of 60%, no hypertrophy of the left ventricle, normal sized atria, and no valvular abnormalities. And his RVSP was normal as well. And then also had an abdominal ultrasound to get a better idea of his ascites, and it showed moderate volume ascites and a heterogeneous and nodular liver consistent with cirrhosis and patent hepatic and portal veins. So given this kind of clinical course, he was initially gotten fluids, and after this was started on Lasix and spironolactone for kind of the dosing that we think about for cirrhosis. And then had some additional labs that kind of started coming back as well. Later on, inflammatory markers were added to his labs, and he had a CRP of 103 and an ESR of 69, had an AM cortisol that was 8.8, ACTH was 18, and then had an SPEP come back that had an elevated IgA, but the kappa lambda and kappa lambda ratios were the normal limits, and the immunofixation was still pending. And then we went back kind of to get some more history and clarify the time course from his daughter and his family, from his wife, because some of the initial history was unclear about the time course, given that he had this like waxing and waning mental status when different members of the team met him. And they said that he, like a few weeks ago, before this fall that worsened his back pain, he kind of had this like generalized fatigue, anorexia, maybe like some URI, and then was feeling ill to begin with, and then had that fall maybe when he was falling down the stairs, and was also kind of feeling like he was losing his balance in the sense when he had those falls, kind of felt unsteady on his feet, and then had like 2 months ago that admission to the ED for black stools, and then had the GI bleed diagnosis. And that's when he was kind of around this time started on opioids and Dilaudid for his back pain. Before that, he had never been on any opioids for his chronic back pain, and then hasn't had any like night sweats, fever, any other like systemic generalized symptoms during this time period. And that's all I have for this aliquot. And then I have another aliquot before the final diagnosis.
Awesome. Maybe I can just start because I think there was a lot there. I think, just starting on the first piece, it sounds like he got fluids, got hypervolemic with the O2 requirement. And then kind of going through with the CTPE, I think especially with the tachycardia and the hypoxia, I'm glad there's no PE, but I think the suspicion for that was low to begin with. And then kind of thinking about ground glass opacities, it could be a lot of different things, but in someone who got a lot of fluids and has other signs of hypervolemia, probably related to fluid. And then we have other signs of the right pleural effusion and the ascites. I know it wasn't mentioned in the physical exam, but are we sure he didn't have any ascites before he came in, or did that kind of develop after the fluids that he received? And then kind of going through with the echo, overall EF probably looks okay. And then otherwise nothing else that really stands out there to kind of think about a cardiac etiology for the hypervolemia. We know he has cirrhosis, so probably less likely, but always something to keep in mind. And then with the abdominal ultrasound showing ascites, I'd love to know, is this the first time he's had ascites? Has he had it before? Do we have a previous TAP? And I think probably pursuing a TAP during this admission. And then I'll kind of stop there.
Yeah, I think additional things that I'm thinking of, kind of going back to the concept of, multiple players when you're talking about hyponatremia. I think a lot of these points that Sowda made are really important, that now we have this this seemingly clear volume up picture. I think you even alluded earlier that there's oftentimes things that happen in the emergency department before we even meet the patient that either give us information or kind of muddy the picture a little bit in some cases, depending on what the circumstances are. I think even several people in the chat mentioned, being very careful about doing things about, giving folks fluid just here and there can kind of change your picture and your workup. And then the kind of move to diuresis is kind of the way to, move this person forward now that we're in this situation where we do seem to have, some extra volume on there with both the ascites. I would also be interested to know whether this is new or all of this happened, and get a sense of what is this gentleman's sodium doing while all of these things are occurring. Is it kind of staying steady? Are we climbing back towards his previous baseline? And then, even though we have these other factors, and there was some question about the emergency department, whether there's volume down status initially. Now we're a little bit more convinced that there's extra volume on board. Some of our euvolemic causes, taking up, now that we've gotten a little bit more information about medications, he's been on some Dilaudid and other opiates, as well as gabapentin, certainly can play into an SIDH picture. I know this is not necessarily a clear mainline only SIDH picture, but is there other factors going on in the background as well besides this hypervolemia? So just things that I'm wondering, especially now that we've gotten the information that a lot of this is brand new for him, or relatively speaking.
Yeah, no, thank you both. I love how there's so much, it's so challenging distinguishing signal from noise in this case. And you both are, I feel like, walking through it in such an authentic way about what's standing out to you, what's still unknown. One question I had, along this theme of distinguishing signal from noise, how are you framing the problem that you're trying to solve in your mind right now? Or in other words, kind of how would you kind of summarize the case or the problem right now?
Sure. So, what I'm seeing here is that we have a 65-year-old gentleman with quite a complicated past medical history, but most significantly for cirrhosis that has seemed to have a fairly recent decline, and with particular complicating factors of decreased mobility and pain and hyponatremia, now with what is more clearly seems to be volume overload. And that's how I'm framing this. I would like all of this to go together in one big bucket. We're certainly presented with this case as, kind of the crux of the case being, why is his sodium so low? And I'm still wondering if this all comes together under the same kind of bucket. And I'm wondering if it might, but that's kind of how I'm framing it for myself.
That was extremely helpful. Sowda, any other thoughts on how you're framing this problem in your mind?
Yeah, no, I think very similarly to Dr. Harrington, kind of thinking about him being an older gentleman and kind of very complex medical history. And then thinking about kind of the things going on now and that being like his hypervolemic state. I think probably if I was taking care of him, I can anticipate that like from a day-to-day basis, I think my framing of him and kind of his main problems probably changed throughout.
Amazing, thank you both. Okay, we can jump to the next aliquot.
Yeah, and definitely as we were taking care of this patient, our problems that we were addressing and our like problem representation assessment was really changing every day because we were trying to figure out which problems are lumped together and which ones are not and which ones are unrelated, and kind of thinking through if we lump like the altered mental status that's been kind of waxing and waning, does that go together with the cirrhosis or does that go together with something else, and kind of does that go together with the hyponatremia, kind of figuring out what the signal and noise was, if you all have been talking about. So in terms of some more like kind of clinical course for him, so initially his sodium had like kind of gotten better after getting fluids, but then he had like that hypoxia episode and had some evidence of volume overload. So then we had like diuresed him. So at this point, his kind of how we were framing him kind of focused more on why is he having this like waxing and waning mental status, and like his sodium was kind of unclear if he's at low to begin with because of cirrhosis and other like ADH things being off. So now kind of thinking more about his mental status, GI saw the patient as well. This was new ascites for him. He's never had ascites in the past, has never been tapped. As far as we knew, his like cirrhosis had been, he had like a admission to an outside hospital where he got a CT scan and they found cirrhosis. But before that, he'd never really known about it. So GI thought that maybe he had hepatic encephalopathy, even though like he didn't have any abnormal labs in terms of the synthetic function of the liver. They thought that is like decline over the past few months with this like unclear mental status changes. They kind of wanted some more workup of this cirrhosis, even though we were all kind of attributing it to his alcohol use. So they sent up like a bunch of autoimmune labs for his cirrhosis, hepatitis, panel, HIV. All of that was negative. All of the antibodies, like all of the cirrhosis workup. His blood cultures were all negative to growth so far as well. And then his urine culture had grown like more than 100,000 mixed flora. So then how we were kind of thinking of it as a team was maybe like his cirrhosis, he had some concurrent malnutrition and deconditioning. So maybe he had back pain in the setting of falls, which made his back pain worse. In the setting of like loss of balance, maybe some sort of neuropathy from his alcohol use, and then kind of has sarcopenia on top of that, increased weakness. So we were kind of going back and forth between like what's causing what and what's related and not. And then he became more agitated overnight, and like his mental status kind of became the real concern for us. Had a new oxygen requirement and was actually intubated because of this concern of not protecting his airway because of his mental status, and transferred to the MICU. And this is where I'll leave you guys, and the next aliquot will reveal the final diagnosis.
Wow, that was a change that I did not expect. I think there was a lot there, and it sounds like our kind of problem representation for him has changed a little bit, and kind of focusing more on the mental status. I think for me, some things aren't quite fitting together as nicely as I would like, especially with his cirrhosis. His underlying cirrhosis and kind of concerns for decompensated picture. I also agree. It sounds like there are some things that GI had mentioned that probably don't fully fit, but especially with how fast he kind of, it sounds like he decompensated. I think definitely things to think about. I think for me, when I think about mental status, just kind of taking a step back with like any patient, I know there's like a lot of different mnemonics and that I really have a hard time thinking about. But I think general things, I think a big one is missed, but general things I think about are any like metabolic causes, like electrolyte derangements, liver dysfunction, kind of CO2, O2 abnormalities, and then thinking about infection is a big one. And then thinking about any like structural things. And then the last one being toxin, especially with his whole, his past like opioid use. I think he has like risk factors for a lot of them with the metabolic, with the cirrhosis. It sounds like he hasn't really had any signs and symptoms of infection, but had this white count. I'm not sure if we got any of the ascites fluid. Did he have SBP and that kind of led to it? It doesn't sound like anything structural, but he has this history of falls. Did he have another fall? Did that kind of cause any changes? And then kind of toxins, thinking about his the opioids that he's been on for his back pain.
Yeah, I will echo what Sowda said, that this aliquot pretty much completely changes our problem representation. It sounds like he got sent in for the sodium, and we've been focusing on this the whole time. But I think what's become clear now is that the sodium is likely a symptom of the larger issue than actually the root cause, especially since Gerlene shared with us that through the various different adding of fluid and taking away of fluid, and the sodium has improved, at least to some degree. And that for me takes that off the table as kind of the underlying cause, but as probably a symptom of a larger problem. I think MIST is a great mnemonic to kind of start working on altered mental status. I think something we haven't really focused on here because he was kind of stably unwell is the infection piece. For me, the SBP is probably high on the differential in that case, with negative blood cultures and things like that. An infection in the ascites can be kind of insidious in some cases, causing this kind of decline. Anytime that you have, and GI is kind of sharing with us, or the primary team, has discovered that this is kind of his first bout of decompensated cirrhosis. And anytime that you have a decompensation for cirrhosis, you really have to ask yourself why. The ascites is new. Is the mental status actually HE? GI thinks so, and I'm happy to take their expertise, but why is this happening for him? Infection is very high for that. Other things that can cause decompensations for cirrhosis are things like portal vein thrombus. I know we've ruled that out here because we have imaging that tells us that he doesn't have that. Certainly addition of toxins, like if he was drinking and continuing to kind of incite that liver injury. We know that he's been in rehab, so he hasn't had access to that. And GI bleeds, he came in with quite a low hemoglobin. We're not getting anything in the picture. We're not getting anything in the story that he's having some kind of ongoing GI bleed. That's something else that can cause a decompensation of cirrhosis. And then something else that we think that could be happening that also can cause a decompensation of cirrhosis for the first time is if there was a presence of cancer. The tempo of this is not that, so it wouldn't be for this case. And so that leaves me often with infection. I know a lot of folks are writing in the chat, they're worried about this CRP and ESR, and certainly an infectious process underlying could play into that as well. And so that's kind of what has started to rise to me. It's getting me so concerned about this guy, and this guy's already bought himself a bed in the unit. So I think we're all concerned about him.
Yeah, something I'll say is what I really appreciate what you both are doing in terms of how you're discussing this case is first, you're kind of walking us through how the problem representation is changing in your mind. I think it's helpful to hear that thought process. And two, Jill, what you just described, asking kind of the why, like why is there decompensation for cirrhosis and walking through those causes and not just stating that there's decompensation. So asking the why. I really appreciated both of that. A question that came up in the chat is, Amir mentioned this, that this patient with cirrhosis, having a high white blood cell count, you mentioned the CRP and ascites. Do you think this warrants empiric antibiotics for SVP, or would you, at this point, what treatment would you do right now, or empiric treatment, if anything?
If we have ascites fluid in the lab, absolutely. This guy's in the MICU. He absolutely deserves antibiotic coverage. I wouldn't wait for the paracentesis if he was unstable in terms of hemodynamics. Sounds like the intubation was more of a mental status protecting the airway. So likely we probably have a moment to snatch a diagnostic para, but yeah, absolutely put the antibiotics on.
Great. And then lastly, I believe, Gerline, correct me if I'm wrong, the next outclot will reveal the final diagnosis. And if that is the case, Jill and Sowda, any kind of last thoughts about what you think is going on with diagnosis?
Yeah, sure. I think with everything going on, I think we have a picture that this is a case of decompensated cirrhosis. I think it's still unclear exactly what caused the decompensation, but I think with how much his mental status has changed and the new ascites, I'm also thinking SVP, but I'm also not 100% sure.
Amazing. And Jill, any last thoughts before Gerline gives us the last outclot?
I'm gonna let Sowda have the last word on that one.
Beautiful. Go ahead, Gerline.
Yeah, so in the MICU, he ultimately underwent an MRI of the spine because there was some concern that is this all process kind of stemming from his spine in terms of this like recurrent faults, these weakness that he kind of attributed to last admission. There's been some concern, and the MRI lumbar spine showed discitis and osteomyelitis at L4, L5 with an epidural abscess extending from L2 to L5 S1 levels. And then at some point he had like a repeat UA urine culture. I'm kind of unsure if that was like right before he went to the MICU or after, and that was growing Enterococcus fecalis. And then the IR aspirate of the abscess also grew Enterococcus fecalis. So I think my reflections on this case were throughout like when we got those inflammatory markers, as Dr. Centaur is mentioning in the chat, we were kind of really confused about this like CRP being high, ESR being high, and how that fit into his entire clinical picture. And we had kind of anchored on like his mental status, but not kind of thinking what else could be causing it. We were thinking like, oh, the sodium could be a contributing factor, the hepatic encephalopathy that GI was mentioning, some hospital acquired delirium into it. So we weren't quite sure. We weren't focusing on the back pain because we thought that this was something he had chronically, and he had a previous admission where his imaging was stable. So I think my reflections were that when things don't fit together, like this high ESR and CRP, you really have to like think more broadly about what you're missing and what you're anchoring on and how you're framing the problem representation of what that core issue might be. And then also like the cognitive error of framing that, thinking that this back pain was kind of the same as before and never really getting a very good back exam, because oftentimes patients in the hospital, we don't like lift them up as much when we're like rounding on them quickly, and might not be like specifically checking for spinal tenderness in very discrete locations. And just that fever is an important diagnostic clue, but the classic finding of like the epidural abscess is when fever is absent, it can really lead to a delayed diagnosis, because as you guys were all saying, we were thinking about like SVP, is this all kind of in the setting of a cirrhosis, but not really thinking about other sources of infection. And then just in the setting of back pain overall, like any elevated CRP should kind of trigger that workup for spinal epidural abscess, which was an important learning point for me as well. and then MRI being a better test than a CT scan for that as well.
Wow, Gerline, what a case. My gosh, thank you so much for preparing all this and presenting. Sowda and Joe, what are your reflections and kind of reactions to this?
Yeah, I think the first thing I thought of was like, wait, it was the back, which is something that we had not talked about since the beginning, and we kind of went down another route. But I think it was always really, I love the point that you brought up, Gerline, of kind of thinking about other sources and looking at going back to who the patient was and what they had initially came back in and whether that's still relevant.
Yeah, for me, I think that this really highlights how often that when there is a lot of noise in a case, that it takes a long time. And it sounds like, Gerline, that your team really experienced this all the way through, that you had presenting complaints that you had to try to figure out. But I think this is what I struggled with during this case was, what is actually the central issue and what is the symptom of the problem? And I think you have to pull on the thread that you have. Certainly hindsight is 2020, and we could all say, oh, well, he had that back pain the whole time, but it sounded like he had some imaging barriers initially and things like that. And certainly some of these other threads to pull on were also useful. And seeing the progression of the case, kind of starting to figure out, okay, the hyponatremia is really just kind of a symptom of everything else that's going on. Let's move on to the next thing. Everything else gives you clues. And then the decompensation of the cirrhosis, I think, is a big clue, because exactly like we were talking about before, that you've got to ask yourself, why is that happening? And what reasons? And I know SBP, Sowda and I both like that a lot. Is our first infection we think of when patients have cirrhosis, but really any infection in any source can cause a decompensation. And so, you've got to go down everything. And, certainly we had other things that were already telling us, okay, it's not in his lungs. We had advanced imaging for that. Maybe we would have, of course, always gotten that ascites fluid, but looking at every single piece of the puzzle and then eventually going back to the back is kind of what sunk it there. So, Gerline, wonderful case.
Yeah, Jill and Sowda, I think I can't thank you enough for being here. And from my perspective, this really was kind of a masterclass in these clinical reasoning topics. We talked about the problem representation, figuring out what the center of gravity is, not anchoring too much, and kind of asking why. And I really appreciate how you both really authentically walked through this case and were clear about at what points you were confused, how you move forward. So I really appreciate you both for just giving us all this expertise. So we can jump to Promise's teaching points now.
Hi everyone, thank you, Arlene, for this wonderful case. Like you said, there are a lot of information, and I'm sure other people may also relate to feeling information overload at times and really trying to sort out like what to really focus on compared to everything else that's going on in the background. And so we really started with like focusing on the hyponatremia part of this patient, and Sowda talked about looking at the patient's past history and like looking into the chart for their lab trends and thinking about the time course and whether or not if the patient is symptomatic, that's a good way to start approaching a patient admitted for hyponatremia. And then we also had like the whole schema that we talked about hyponatremia. We wanted to look at the serum osmo and then the urine sodium and also urine osmo. And then we wanted to look at their volume status to know if it's hypo, hyper, or euvolemic status. And then we talked about like looking into how can we use physical exam to kind of accept the status, which we talked about how usually we're pretty good at detecting hypervolemic status, but not very good at differentiating between hypo or euvolemic. And then we kind of got more information and we
change the problem into thinking more about a decompensated cirrhosis picture. And we talked about the most common causes for that. And it's really important to ask why this patient is having this. And so with infections, SVP is something that we will always think about, but Dr. Jill mentioned that we really have to think about from any other source like this patient. And then it could be like toxin, GI bleeds, or even malignancy. And I think the biggest takeaway for me from this case is really just, it reminds me of Reza's, he always says doing a cognitive biopsy every step along the way, and kind of thinking if things are not really fitting into the picture, like what is going on? Like, did I miss anything, or am I anchoring on anything too much? That I have to go back and like look at this whole picture one more time to see, like, how can we approach this problem one more time, and what was the error that I was making in my reasoning process. So thank you everyone for the participation. I learned a lot. And thank you, Gerline, for the amazing case. And thank you, Sowda and Dr. Gill, for this amazing discussion.
Beautiful teaching points, Promise. Thank you so much. And thanks everyone. Thank you, Gerline, for presenting, and Jill and Sowda for really a phenomenal discussion. Thanks everyone.